Hello, my name is Jackie Sandmans, and I will be talking about the Coroners Report that was delivered in December 2018 about the death of baby A as a result of hypoxic ischemic encephalopathy. A little bit of history on the woman in question is that she's a 42-year-old woman. This is her first pregnancy. She's previously had one miscarriage and two pregnancy terminations. At her 37-week clinic appointment, the doctor found that her blood pressure had increased to 150 to 160 systolic, which is an indication that she was developing preeclampsia. As a result, the doctor ordered blood tests as well as prescribed labetalol twice a day. The woman was also ordered to continue checking her blood pressure every day, as well as to have an ultrasound for fetal growth and well-being. At this time, the woman was also advised that water immersion was contraindicated due to high blood pressure. The woman was admitted to the hospital previously for high blood pressure. At 9 p.m. on the 7th of June, the mother went into spontaneous labour and started contracting every 3 minutes. Her waters broke while she was at home at around about 10:30, and the woman claimed that it had a greenish tinge when the water broke. It is noted that the family were aware of meconium, and the father took a sample of the discharge to show the midwife at the hospital. The parents arrived at the hospital at 11:30 that night, and she was attended by midwife P, who gathered a basic history, including when the contractions started, and it is noted that there was clear fluid draining as well as vaginal brownish discharge. A VE was completed and she was 3 centimeters dilated. At that time, the woman's liqueur was pink, bloodstain. This is when the first critical point occurred because the family said that they had brought in a sample of the fluid. However, there is no documentation about the midwife seeing the sample. Besides the note of the liqueur having a brownish tinge, all of the documents state that the liqueur was bloodstained. It is also of note that aside from 2 recordings of bloodstained fluid for the last 4.5 hours of labour, there is no mention of the fluid colour. This can be a warning sign as the colour was not documented since the woman went into the bath and the fluids could have been dispersed in the water. At this critical point in the timeline, it is important to make sure to document all information and history that the midwife gathers from the woman. In this case, making sure to document where the sample was collected and received by the midwife. According to the normal birth clinical guidelines, the vaginal liqueur should be monitored hourly for colour. The clinical guidelines also discuss discontinuing water immersion due to meconium or bloodstained fluid being noted post-strom. This is especially relevant given the fact that the notes of the coroner's report discuss bloodstained fluid before the woman entered the bath. The next critical incident that was noted in the coroner's report was the use of fetal monitoring during the admission to the labour ward. When the woman first presented to the labour ward, the midwife started an admission CTG, which is a normal procedure to assess the fetal heart rate baseline as well as the strength and regularity of contractions. In this case, the 20 to 25 minute admission CTG has been documented to have a baseline of 118 to 155 beats per minute, which show that there's no clear baseline. Dr. E, who reviewed the CTG post-birth, noted that the CTG trace was non-reassuring and not reactive, with evidence of late deceleration. It is not documented whether the midwife had another midwife review the CTG before removing it, or whether she discussed the CTG with the doctor. The CTG was not reapplied once the woman had been moved over to the birth suite. However, intermittent auscultation was used while the woman was in the bath. The appropriate midwifery intervention that should have been utilised at this point in the timeline would have been to check the CTG, to keep the CTG on and have another midwife check the CTG before removing it. It is also important that a doctor reviews the CTG, especially if the midwife has any concerns. I, as a practicing midwife, would have taken these steps, in addition to making sure that the woman understood that we need to continue monitoring the fetal heart rate before transferring over to the birth suite. Therefore, she may not be able to have water immersion during labour. Monitoring the fetal heart rate should be undertaken as per the RAND's core guidelines, which includes the fact that the woman who requires continuous fetal monitoring may use water immersion if adequate telemetry equipment is available. If the midwife is unable to gain good trace during labour, even when using telemetry, then the woman may have to leave the bath in favour of other non-pharmacological pain medications such as gimbal or the utilisation of the shower. At 12:30, it is noted that the woman was in the bath and using gas for pain relief. This is the third critical incident that occurred during the woman's labour. It is noted that both the doctor and the midwife discussed water birth both antenatally and on admission to the hospital. However, the midwife still allowed the woman to enter the birth suite with a bath. This is dangerous, especially if the midwife is not confident in advocating for the woman or the baby's safety. Water births can be dangerous, especially for high-risk pregnancies, which require close monitoring. As a result of using water immersion, continuous CTG monitoring was not used and only intermittent auscultation was utilised. In this instance, I believe it is important for the midwife to discuss her concerns with the family, as well as to reiterate the fact that the woman needs to be on continuous monitoring for her and her baby's health. Therefore, water birth is contraindicated. Other contraindications for using water immersion include the history of the high blood pressure, which requires close monitoring, in addition to the abnormal admission CTG. All women have the right to make informed decisions, including to consent or refuse any procedure or treatment. However, midwives have the responsibility to ensure that the decisions made focus on the safety of the woman as well as the baby. In my experience, I have found that women are open to changing their birth plan if they understand that their plan can harm their baby in any way. From 12:30 when the woman went into the bath until 2:30 when the doctor arrived at the hospital, the midwife did intermittent auscultation of the fetal heart rate using a Doppler every 30 minutes for approximately 1 minute after each contraction while the woman was in the bath. It is also noted that from the time of admission at 11:30 until 2:30 when the doctor arrived at the hospital, the woman's blood pressure was checked 3 times. This is the fourth critical incident of note, as it is noted that during the pregnancy the woman was having high blood pressure and was being medicated. It is noted in her admission that her blood pressure was 184/91, which is classified according to QMUTS as warranting a MET call due to having a high systolic reading. However, a MET call was not issued at this time, and the doctor was not even notified for another hour and a half after the blood pressure was completed. At this time, the doctor prescribed an IVC to be inserted and bloods to be taken, as well as monitoring the blood pressure regularly. At 12:30, the woman's blood pressure was 159/91, which is trending down. It is noted that the blood pressure is checked every hour at this point. However, from the arrival of the doctor at 2:30, there is no mention of blood pressure until she's up in theatre. This is dangerous because it means that the midwife is not closely monitoring what the woman's blood pressure is doing during labour. There is also no mention of any medication being administered at this time, and the doctor did not come and review the woman until 4 hours after she was admitted to the hospital, even though the doctor was informed at 12:15 about the high blood pressure. I, as a midwife, would have asked the doctor to come in as soon as possible. I would have also checked the blood pressure more frequently as per the QMUT guidelines. At 2:30, when the doctor arrived at the ward, he took over care for the mother. The woman remained in the bath despite having a high-risk pregnancy. At 2:45 and then 15 minutes later, a vaginal examination was conducted on the woman in the bath. This may lead people to believe that the midwife is unsure about the VE. At 4 a.m, the woman got out of the bath and a VE was conducted by the doctor on the bed. It is noted that she was 9 centimeters dilated and the head was in the LOP position at this time. The bladder was drained at this time using a catheter, and a urine sample was collected, which showed high levels of protein. While the woman was on the bed, the midwife attempted to place transducer straps on the mother, which was difficult as the woman was moving around on the bed. At 4:45 a.m., after a trial of pushing, the doctor conducted another vaginal examination where he found signs of careful pelvic disproportion with suspected narrow pelvic outlets. It was at this stage that the doctor suggested a cesarean section. The fifth critical incident that is noticed was that the midwife was unable to do continuous monitoring because someone was moving around on the bed. Dr. S did acknowledge that the CTG trace was not satisfactory due to the woman's movements on the bed during contractions. If telemetry is unable to get a good trace, then the fetal scalpel electrode may be used may be placed on a baby. The fetal scalpel electrode allows for more accurate reading of the fetal heart rate, which means that the doctor and the midwife would be able to accurately determine the health of the baby during contractions. At 6 a.m., she arrived at the theatre, and the surgical team took over and performed a spinal block. At this time, her blood pressure was 120 systolic. While in the theatre, the fetal heart rate was only checked intermittently, where a fetal scalpel electrode could have remained in place until the doctors were ready to operate. The baby was born at 6:35 a.m. on the 8th of June. He was not breathing at the time of his birth and was covered in thick meconium. He was immediately transferred to the resuscitator in the operating theatre, and resuscitation was performed by the paediatric doctor for approximately 17 minutes when the heartbeat was detected. The APGAR scores were noted to be 0 at 1 minute of life, 1 at 5 and 15 minutes of life, and 3 at 20 minutes of life. The baby was moved to special care nursery and placed on life support. The doctors consulted with the director of neonatal intensive care unit at another hospital, and after consulting with the parents, a decision was made to cease the life support. The baby was declared deceased at approximately 11:10 a.m. on the 8th of June. What we can learn from the coroner's report is that the risk of meconium aspiration during labour, especially for women with preeclampsia, is profoundly serious. There are times when water immersion is a useful tool for pain relief during labour. However, the woman should meet certain criteria before being allowed to have access. I believe that if the midwife P had got someone else to check the CTG on admission and had continuous monitoring on the woman during labour, then the midwife and the doctor would have been better prepared to intervene when complications arose. I believe in the future, when I practice, I will be more aware of the risks associated with meconium aspiration. I have not had any experience with water immersion during my studies. However, it does interest me to learn more about it.